second Soteria in the pub event. It's not quite a pub. We did have a pub for you in January, but unfortunately Joanna couldn't be with us because she's unwell, but delighted that she's fully fit again. This is the second Soteria in the pub event we've done. The first one some of you might have been at was with Robert Whittaker about a year and a half ago. And the idea is that every so often we'll invite people to come to talk who have inspired us in the field of mental health to come and talk about their work and also to be in conversation with us. We'd like this evening to be as kind of conversational and dialogical as possible. The idea is that the second half of the evening we'll have questions from the audience, but if there's any pressing question in the first half that you feel that you really you want answered, then do chip in. So first, just to let you know a little bit, for those of you who don't know about Soteria Brighton Group. The Soteria Brighton Group's been going for maybe 2 to 3 years now. We're gradually, and it is fairly gradual at the moment due to the resources in the group, working towards opening what we Soteria House in Brighton, which will be a residential community for people experiencing psychosis. Probably what we call first episode psychosis, but not necessarily exclusively. We haven't worked everything out. To some extent it will depend on what's possible for us to do, what we can get funding for. But the idea, the original Soteria House was set up in San Jose, California in the 1970s. And, essentially what they were trying to do was to see whether people, instead of being in hospital, could do just as well or better in a residential community that would have more of a family-like feeling, where people were not necessarily prescribed neuroleptics. If they were prescribed anything, it was more likely to be tranquilizing medication, but some people did use neuroleptics, but only when needed. And I think if there's one thing that comes out of the talk this evening, it will probably be something around not using neuroleptics routinely, but only as and when needed, and a more need-adapted system of care. So what they found in this original house in San Jose, it was run by Lauren Mosher, was that people did just as well. They tended to stay about twice as long as they might stay in hospital, but only about 40 to 50% of people took neuroleptic medication, and those people that didn't take medication had the best long-term outcomes. But there was like a lot of research in these kind of fairly small settings. There are questions about the research and need for replication, as there is with some of the open dialogue research. But it was nevertheless a very encouraging start, which has inspired a number of projects around the world. So the next project was a second house that opened in the USA, and then there was a project in Switzerland, in Bern. Currently, there's a house in Alaska, in Anchorage, Alaska. That's opened, and there's one that's going to be open in Vermont soon as well, and we hope that we want to open in Brighton. So that's essentially what we're working towards. It's an alternative to hospital for people experiencing psychosis for the first time. So that's Soteria Brighton, and as well as being an opportunity to hear from Joanna and be in conversation with Joanna about her work and her writing, it's also an opportunity this evening for us to raise funds for our development work. So there's various ways that you can support us. You supported us by coming here, but there's also a raffle. So if you haven't managed to buy raffle tickets, Sarah will gladly sell you some more raffle tickets in the break. There's also a bookstore where you can buy books related to the theme, which include Joanna's latest book, which I'll mention in a moment. And also you can make donations in our donation tin. So if you've got any loose change weighing you down, feel free to put it in one of our donation tins. Okay, so now it's my pleasure to introduce Joanna to you. I've only had the pleasure of meeting Joanna briefly on 2 occasions, but I've heard an awful lot about her on my travels sort of in this country and also internationally, amongst people who are trying to develop what I would consider to be more progressive and compassionate responses to people in distress. Joanna's name often comes up as a very progressive and free-thinking psychiatrist who's, I suppose over the last 10 years in particular, has articulated a a lot of the concerns that many people have with the way in which psychiatric, well, I guess the profession of psychiatry has developed, and in sort of conventional services, and problematics with the routine use of neuroleptics. It's very inspiring to read her books, not only because of what she's writing about, and this is the latest book which I just finished reading, and it really does thoroughly go through. I mean, every piece of research that I heard of in different courses before is covered in this book. Sort of the 60-year history of the use of neuroleptic or antipsychotic medication, and the implications of the research and the should we say the behaviour of the drug companies, and it's a fantastic read, and it's also a very, very clear read. What I like about her writing is how clear and accessible it is. So, Joanna is, am I right in thinking that you're co-chair of the Critical Psychiatry Network? Yeah. As well as being a practicing consultant psychiatrist, she's also a senior lecturer at the University College of London. And she's here tonight, I think, primarily to talk about this latest book, The Bitterest Pills, and her work generally. And she's going to talk for a while, and then I'm going to ask some questions. And then after that, we'll go into a break, and then we'll have more questions from the audience afterwards. So, welcome, Joanna.
So thank you all for coming, and I'm really, really sorry to people who had tickets booked in January about having to cancel it then. I really could not have managed to get down to Brighton at that time. It was nice to be here for sunny evenings. Thanks very much for that very flattering introduction, and I feel embarrassed really because I certainly don't have any answers to the profound problems that we call mental illness today, mental disorder, mental illness. What I've been trying to do is promote a more honest attitude to the drugs that we give people for those sorts of problems, so that we use the drugs more cautiously, more wisely, so that they cause fewer problems. And thinking about what Nick said about Soteria, one of the reasons I think Soteria is really important here is when I started as a trainee psychiatrist over 20 years ago, quite a number of consultant psychiatrists would routinely, if someone was having a psychotic episode, they would admit someone to a ward and observe them for at least 2 weeks if it was a first episode before they started any medication. And that was because it was recognised firstly that it was a serious thing to give someone an antipsychotic and to diagnose something like schizophrenia or even a psychotic episode. And that, of course, that practice has completely disappeared. It would be unthinkable nowadays in our very pressured inpatient environments that anyone could be sitting around for 2 weeks, with psychotic symptoms before the drug treatment started. So somewhere where there is an alternative, where people do have the opportunity to see if they can get through a psychotic episode without drug treatment. It won't be possible for everyone, but to see if they can, I think it's really important. Okay, so I thought I'd talk about how I came to write this book and why I got interested in drug treatment, why I got interested in antipsychotics, and then tell you a bit about what's in the book. And I have to start off by explaining and apologising for using the term antipsychotic. Of course, everything that I've been writing over a number of years has suggested that it's the wrong term, that these drugs are not specifically targeting psychotic symptoms. They're doing something much more global to the brain. And one of the problems, one of the dishonesties in the way that we think about, the way that the psychiatric establishment thinks about its drug treatments, is this way of portraying them as if they are doing something specific and sophisticated. So I much prefer the older terms, neuroleptic, which was coined by the 2 French psychiatrists who first used chlorpromazine, and means to seize the nervous system. And they borrowed that term from the French surgeon who gave them the idea of using chlorpromazine in people with mental health problems. And he called these drugs neurological inhibitors, which is maybe even better actually. And then of course the English-speaking world for a long time called them major tranquilizers. So all those terms are much better because they describe what the drug is actually doing to someone instead of trying to pretend that it's reversing some underlying disease. But I decided I had to go with antipsychotic when I asked one of my GP trainees, when one of my GP trainees asked me what a neuroleptic was. So that's a qualified doctor, and she didn't know what it was. So I'm afraid the term antipsychotic has permeated our culture so completely that I felt I had to use it. So, to try and summarise why I got interested in psychiatric drug treatment, I will remind you of a BBC documentary that was probably done 15 or so years ago that was filmed at Springfield Hospital, and one of the main psychiatrists being featured was Tom Burns. I can't remember what it's called, and I don't know if anyone's seen it. But basically, they followed this psychiatrist, Tom Burns, around with a number of his patients from a community team. Can everyone hear me all right? And I videoed it. I videoed it, and I happened to watch it. I happened to watch the end of it first, and then go back to the beginning. So the last scene is Tom Burns, who I have a lot of respect for, especially now. He's the person who's done this big randomised trial of community treatment orders and found that they're not effective, and strongly recommending they should be ditched, they shouldn't be used. Anyway, in this documentary years ago, the last scene is him sitting opposite this patient, who's an Afro-Caribbean man, who's rather overweight, sitting very still, not drooling a lot, but drooling a little bit, and answering questions in a very monosyllabic way. So Tom Burns, the psychiatrist, says, are you feeling better? He says, yes. Are you having any problems in your daily life? No, that sort of thing. And Tom, after a little bit of this interaction with these monosyllabic replies, Tom Burns says, "You're looking so much better now." And just seeing that scene was so unbelievable that a psychiatrist could really think this person who was obviously drugged was really better and back to normal. And then I rewound to the beginning of the program, and you see this man in his own house with some very bizarre ideas. Admittedly, he thought he was the Queen of England. But animated, lively, articulate, able to talk and converse and respond to the people the film crew and the people who were talking to him. So I became interested in why was there this massive gulf between the way that many of my colleagues saw things and the way that I saw things. Why was it that some psychiatrists were able to convince themselves that the drugs they were giving were putting people back to how they were, making people normal again, targeting something underlying in a very sophisticated way, when it seemed to me clearly the case that people were suffering from drug-induced effects. Those effects may have suppressed their psychotic symptoms, but had suppressed them in other ways as well. And I remember at that time wondering why it was that we were taught that people who were given antipsychotics would sometimes show Parkinson's disease-like symptoms as a side effect, and that was clearly separated from the idea, from any idea about what these drugs did to people in a therapeutic way. It seemed to me that there must be a connection between the fact that people expressed themselves less and therefore were less likely to manifest psychotic symptoms, and the fact that they were slowed up and shuffling and stiff and showing other signs of Parkinson's disease. And I didn't realise at that time that the psychiatrists who'd first used these drugs, the French psychiatrists Pierre Dennecker and Jean Delay, had been well aware of this. And in fact, many psychiatrists in the 1950s connected the ability of these drugs to induce a Parkinson's disease-like state with their therapeutic properties. They were that's why they were thought to be useful, because they slowed people up. They gave people a sort of mini dose of Parkinson's disease. People were much more honest in those days. So I got interested in drugs because there seemed to be such a divergence between the way that I saw their effects and the way that other psychiatrists saw their effects. I wanted to write about antipsychotics, partly because it was the only major class of drugs that David Healy hadn't already covered in a specific book. But more than that, because although I say lots of awful things about them, I do actually think they are useful. And I work in a community mental health team with people with chronic psychotic problems, a lot of people who are really quite impaired and have been for many years, and other people who have periods when they are psychotic and periods when they come out of that. And I do think the drugs can be useful for some people for some periods of time, sometimes for some people for longer periods of time. But when I started writing, I realised that actually one of the things that's been happening over the last few years that these drugs have been heavily promoted to other people, to people with much less severe impairments. And in fact, it's been obvious that the pharmaceutical companies have tried to make them into the new antidepressants, or tried to get a bit of the antidepressant market for these antipsychotics, especially as some of the antidepressants were coming off patent. I was also particularly interested in antipsychotics because I think they're the group of drugs that shows most clearly the transformation that I've been interested in from the older view that someone like Pierre Denneker took, that did acknowledge that drugs were mind and body altering substances, that they put people into different states. And the new view that came along in the 60s and 70s, that they were disease-targeting treatments. You can really chart that transformation in the literature of antipsychotics. You can, for a little while in the 70s, the two views bump along together a little bit until the disease-targeting, disease-centered view takes over and wipes out the other view. And so if you go back to the literature of the 50s and 60s, people like Pierre Denneker and Jean Delay, they were interested in what sort of effects these drugs had. They actually described what they saw with their eyes, how these drugs changed people in a way that a few decades later people had stopped seeing that, as Tom Burns wasn't really seeing that in that documentary. Sorry, I've got to. And you can also see as this disease-centered view emerges, you can see why it was useful. And the first sort of scandal episode that makes it clear why it was useful is the emergence of tardive dyskinesia. The old view that these drugs were neurological inhibitors, that they were powerfully altering the nervous system and the brain, would have made tardive dyskinesia completely understandable. Maybe unpredictable, maybe not, a fairly idiosyncratic reaction, but nevertheless not that surprising that these powerful brain nervous system altering drugs might produce these this nervous system damage that results in these abnormal movements. The disease-centered view allowed people to parcel this off as an inconvenient side effect, an annoyance, but nothing that really detracted from the fact that these drugs were, the only ever established disease-targeting treatment. And you see with tardive dyskinesia, it's the first time that you see this attempt to deflect the effects of the drugs onto the condition, trying to blame the condition. So a lot of people, a lot of leading psychiatrists in the 1970s and into the 80s put a lot of effort in trying to show that tardive dyskinesia was not to do with the drugs. It was just a feature of having severe schizophrenia. So someone, for example, a psychiatrist called David Owens wrote about a group of patients in a hospital in Scotland who'd been on a therapeutic community ward and apparently not had any neuroleptics. And he described how they showed a range of abnormal movements. But subsequent critics have gone back to those papers and seen that actually very few of these movements were typical tardive dyskinesia, and the people who were on the long-term drugs were getting a different sort of abnormal movement. It's true that people that people who'd been long-term inmates in the old asylums, that some of them did have some strange movements. But nevertheless, it was fairly well established that antipsychotics were causing this particular sort of abnormal movement by the 1970s. That didn't stop people trying again and again to show that it wasn't the drugs. And the same thing replayed itself quite recently with the atypical antipsychotics and weight gain. So Eli Lilly had a deliberate campaign, and it's come out with the release of the Zyprexa papers during the court case in America. They had a deliberate campaign to persuade doctors that the weight gain associated with atypicals and the diabetes they could induce was actually part of the schizophrenia, that schizophrenia caused or was associated with diabetes. So they sponsored a whole conference, out of which came a load of journal papers trying to track back the association between schizophrenia and diabetes. It was obvious to everyone, that some of these atypical drugs in particular were making people put on a lot of weight, and they were obviously frightened that that might impact on their sales. And I remember sitting in talks given by, and these were the doctors from Eli Lilly as well, not just the drug reps, where they were trying to convince us that that the diabetes and the weight gain were due to the schizophrenia. And the most obvious example of this, not that the drug companies have particularly been involved, but is the whole saga about antipsychotics and brain shrinkage. So Peter Breggin, who I'm sure you've heard of he's a psychiatrist who's been very critical of psychiatric drug treatment in particular and other physical treatments. He's been saying since the 1980s that the fact that if you scan the brains of people with schizophrenia, you find that they're a bit smaller and the cavities are a bit larger than if you scan a group of people without schizophrenia. He's been saying since the 1980s that this is a result of long-term drug treatment. And he was just dismissed as being a complete lunatic. And I have to confess that even I thought, oh no, that's too extreme, surely they can't possibly do that. But over the last 10 years or so, there's been increasingly good evidence that they really do. It started with a randomized controlled trial funded by Eli Lilly, where they compared olanzapine and haloperidol, and at the same time as doing the randomized controlled trial, they were also scanning people, and they had a control group. And they found that after 12 weeks, people in the haloperidol group showed some shrinkage of brain matter. And by a year, the people in the olanzapine and the haloperidol group showed shrinkage, but the olanzapine, it was slightly less. So in the conclusion to the paper, they state that olanzapine, they think, is slowing up the underlying process of brain deterioration more than the haloperidol. And then very much in the sort of small print, buried at the end of the discussion, they say, it is possible that the drugs might be causing this, or at least the haloperidol. They wouldn't acknowledge that olanzapine had done anything. It is possible that the haloperidol might have caused it. That is an alternative explanation. Anyway, on the back of that, they apparently then funded, Eli Lilly this is, funded a study with macaque monkeys, who obviously didn't have schizophrenia. And they compared haloperidol, injections, olanzapine injections and a placebo injection, and they were very careful about titrating the doses so they'd be equivalent to the sort of doses that people are given who might have a diagnosis of schizophrenia. And after about 18 months of follow-up, they found that the monkeys in both the drug groups had a 10% reduction in brain weight. So you'd think there's not much arguing with that and that would be massive news, but even I didn't get to know about that for several years. No one really seemed to take any notice at all. And it was only a couple of years ago when an American psychiatrist called Nancy Andreasen published a follow-up of her cohort, a cohort of people with first episode psychosis, and showed that the reduction in their brain volume was very strongly associated with their amount of exposure to antipsychotics, that this issue got any publicity at all. Nancy Andreasen did an interview in the New York Times, I think, and admitted that it seemed that her data showed that antipsychotics caused brain shrinkage. And it now seems that a lot of psychiatrists now accept that, although there are still plenty who still don't know about it. So you can see that if you have the drug-centered view of what antipsychotics do, that's the view that they're mind and body altering substances, that they have their therapeutic effects by causing a state of neurological suppression. Again, it doesn't necessarily surprise you that the drugs might have this effect. If you have this idea that there's some sort of sophisticated, targeted treatment, then you might have to accept that they cause this effect, as the establishment had to accept tardive dyskinesia, but you can still put it in the list of side effects. It's still a secondary consideration. Another reason that I think the disease-centered model has been so important and influential is because it has transformed the way that we view coercive treatment. It's transformed it. It's transformed. If you give someone who's shouting and causing a disturbance in a psychiatric ward, if you leap on them and give them an injection of haloperidol, if you see that as a specific treatment for their psychosis, you can call it treatment, can't you? Rather than control, containment, behaviour modification. You put something really well in your suggested questions to me. You said something like, the disease-centered model offers guilt-free treatment. I would say it offers guilt-free psychiatry by presenting what we're doing as treatment.
Yeah.
But
you also make the point in your book that for some people may well prefer straightforward sort of physical restraint to being sort of forcibly injected, that it's a sort of a more honest form of restraint in a sense.
Yeah. There was a German study I found that actually asked people who'd been victims of physical restraint what they would prefer, of forced drug treatment, what they would prefer, whether they would prefer that or physical restraint either in a padded cell or a straitjacket.
Yeah.
And they almost all opted for physical restraint. And that's why I believe antipsychotics have become the standard treatment for aggressive behaviour, even though there are plenty of other sedatives which are in fact used, but aren't highlighted in the textbooks, aren't seen as the primary treatment, that are just sort of add-ons. And the other thing that the disease-centered model has done very effectively over the last few years has enabled the drug companies to expand the use of antipsychotics. And this, I think, is really, really worrying. And so if you look at the drug company websites now for antipsychotics, which are still on patent, they all talk about chemical imbalances and how the drugs may be working by reversing a chemical imbalance. And my favourite one is from the Eli Lilly site again, which says olanzapine, how does it put it? Sorry, olanzapine. Balances the chemicals found naturally in the brain. as if it's, you know, some sort of homeopathic treatment, or yes, organic, exactly. So, and I think that just shows you why this metaphor of the chemical imbalance, this idea that these drugs are rectifying, bringing you back to a nice balanced sort of state, is so useful for the companies, and has enabled them in particular to widen the idea of bipolar disorder. They went and got a license for treatment of bipolar 1, but this idea has enabled them to bring in all sorts of people who might previously have thought themselves to be depressed, might previously have thought themselves to be anxious, might previously not really have thought themselves to have any problems, and given them the language in which to frame their problems as bipolar disorder so that they can then be prescribed an antipsychotics. And one really, I mean, I was challenged by someone at a meeting who said that they'd been diagnosed with bipolar, they were on quetiapine, and they found it very useful. Fair enough, quetiapine is, you know, it has some sedative effects. It's probably not as unpleasant as some of the older antipsychotics like haloperidol. But the point is, they haven't been tested in people without the classical manic depression bipolar 1 condition. The tests, even in people with that diagnosis, are very flawed. But even if you accept them, they've not been tested in other people. We have no idea, therefore, really, whether they've got any benefits at all, or whether their benefits are likely to outweigh their, you know, serious adverse effects. So, how long have I been going on for? Do you want me to stop?
A few more minutes. I mean, it's up to you.
I think I should just talk about how I think antipsychotics should be used, if at all, and talk about long-term treatment. So, first of all, what are antipsychotics? I think that's the first thing that we need to think about. And the short answer is a mixed bag of chemicals, all of which seem to suppress the nervous system in one way or another, but different ones do it in different ways. So some of the newer drugs seem to have a slightly different profile of effects from some of the older drugs. But in my view, when they are helpful in psychosis, what they are doing is having some suppressant or subduing effect on people's mental processes. And when someone's mental life is completely taken over with psychotic thoughts and ideas, that suppression can sometimes, I think, be helpful. It can enable some normality to come back. They also suppress emotional responses. It's one of the things that people find most unpleasant, this sort of emotional dampening effect. But it can help people distance themselves from their delusions or psychotic experiences. And in fact, Pierre Dennecker, the French psychiatrist, pointed this out in the 1950s or 60s. He said that he felt that the drugs actually make people lose interest in their delusions. The delusions don't necessarily change or go away, but people have a different emotional response to them. So I think they can be helpful for people who are very acutely psychotic. Some people are psychotic unfortunately, a few people for very, very long periods. Maybe those people need antipsychotics for long periods. Maybe they don't benefit from them. I don't know. I think that's a really difficult area because, of course, the tests are all short-term. The other group of people that they're given to, though, and this is what worries me, is people who have an episode, get better, and then they're given these drugs with the idea that the drug treatment will reduce their risk of having a future relapse. And it seems to me that this is the group of people where there's really a fine balance. You know, if they do reduce the risk of relapse, there's also all the other risks associated with taking them long term, which might well cancel out that benefit, if indeed it is a benefit. And this was published before the publication of a really important study from the Netherlands. I don't know if people have heard of that. And when I finished this, before this study was published, despite many conversations with Robert Whittaker, I wasn't really sure about long-term antipsychotic treatment, whether the balance favoured taking it for some people. I'm sure that certainly not for everyone. I never believed that, but whether it might favour taking it for some people or not. In last July, a really important study was published. This was a 7-year follow-up of an antipsychotic discontinuation randomised trial. So it was done with people with a first episode psychosis, and people were, after they'd recovered and were stable for a few months, they were then randomised either to continue with their antipsychotic at more or less the same dose, the maintenance treatment arm, or to reduce their antipsychotic gradually with their psychiatrist, with some support, with the use of other medication if necessary, and possibly going back to the antipsychotic if necessary. At the end of 18 months, that study reported that in the discontinuation group, there'd been more relapses, about twice as many relapses, and therefore their advice was same business as usual, same conclusion as before, maintenance treatment is better, that's what people should have. Unless people totally refuse, but that's what we should be, psychiatrists should be recommending. The 7-year follow-up showed that the group that had been randomised to antipsychotic discontinuation had twice the rate of recovery than the other group. And the relapses had evened out. So the group on maintenance treatment had had more relapses and caught up. Generally, the relapses, certainly in the first 18 months, were in any case quite mild, probably because there was a lot of sort of support and this discontinuation was done very gradually. Not everyone was discontinued. In fact, the majority of people did not discontinue antipsychotics. Only about 20% discontinued completely. Another 20% or so got down to very low doses of antipsychotics. And if you combined those groups, the low dose and the people who discontinued at the 7-year follow-up, they were also doing better than the people who were on maintenance medication. So I think this study has been really helpful. I'm hoping we might be able to replicate it in some way in this country. And I think what it suggests is that I think it gives mental health practitioners a really clear direction. We have got to try to take people off these drugs. It would be nice if we got fewer people started on them in the first place. But if people do get started off on them, we've got to try and take people off. And we've got to be supportive about that and not necessarily panic if people deteriorate. There was this idea that, if people have a relapse, they get worse and worse and worse, and so, allowing people to have a relapse is a catastrophic thing, and it's going to make people lots worse and then never get back to how they were before. Actually, if you look at the literature, people do get back to how they were before. So even if they do have a relapse, it's not the end of the world. So I think that study really helps to give a direction now for the use of antipsychotics, that if people do get onto them, they should be helped to get off once, but not just once, twice, and repeatedly. Obviously not forcing people to, but giving people that opportunity and supporting people to do that. So I'll stop there.
Is that the Harrow study that you were talking about? Is that a different study?
Ah, yeah, and I'll mention that.
Because that has some similar findings.
The Harrow study was a cohort study, so that was just following up a group of people and looking at the people who stopped their antipsychotics of their own choice. And so it was always heavily, it could always be criticised because people would say, oh, well, people who stopped antipsychotics were the people who would do better anyway.
Yeah.
That study, as you know, also showed that the people who had fewer, were using antipsychotics less, did better than people who were using them continuously. So the thing that's so important about the Dutch study is it was randomised. Right. So that
argument's not there.
Criticism cannot be levelled at it. Yes, these groups were randomised. They're not self-selected in any way, and the difference in social functioning shows up between the randomised groups, as well as between if you just analyse people according to what medication they were taking. So yeah.
Well, I'm aware that I introduced you as a progressive psychiatrist, and I think in many respects, given the current climate, you are. But in some respects, what comes across in your book is you feel most identified with some of the early psychiatrists around when medication was first introduced, that they're more closely aligned with the drug-centred model that you speak of, and the idea. I think you talk towards the end of the book about sort of drugs as the lesser of two evils. You know, that if for a period of time these drugs, even if they do have some unwelcome effects, do help people manage the extremes of their experience, then they're useful. And in a way, they seem to be saying something similar, that yes, we might even expect some brain damage with these drugs, you know, given, you know, their powerful effects, but it could be the lesser of two evils.
I wouldn't want to idealise them too much, because this was the era of, you know, lobotomy.
Indeed.
Everyone had ECT, insulin, chemotherapy, all sorts of horrendous things were done to people in psychiatric hospitals. And I think that is partly why they were able to be so honest about the drugs, because there was this, I can't really track it in the historical literature, but there seems to have been this understanding for decades, possibly going back to the 19th century, that the way to get rid of one disease was to give you another. So, you know, ECT was giving people epilepsy to cure schizophrenia, insulin chemotherapy was giving them diabetic comas to cure schizophrenia, lobotomy was giving them brain damage to cure schizophrenia. So that idea seemed to be in the ether. Yeah. And I think that's why Pierre Denneker could be as frank as he was about the fact that antipsychotics, well, he wasn't just frank. He talked about how they caused brain lesions, visible brain lesions in animal studies, and he was reporting this as a good thing to show that, you know, that clearly they therefore worked. So I don't want to idealise them, but I think, you know, when you read their writing, you get a much clearer picture of what these drugs do than if you read the literature nowadays. So, for example, when atypical antipsychotics came in, and even to this day, it's almost impossible in the psychiatric literature to find out what they actually make people feel like, what they do to people. There's no... So in the 70s, a few psychiatrists took neuroleptics and wrote up their experiences. There's nothing like that, you know, from the 1990s onwards. And you know, you have to... There's lots of information like that now, if you go to the internet, from people who've taken these drugs. But nothing in the scientific literature at all, because it just didn't interest people. All they were interested in was what dopamine receptor were they affecting. Yes,
yes. Well, you make that point that, well, I'm just sticking for a moment on the you know, the Pierre Denneker and some of those early psychiatrists who were around by the time the drugs were first introduced. There was more of an idea there that the drugs weren't sort of illness specific, that they had effects, and we need to look at what effects they have on people. And with the move towards the DSM, it's been much more important, you know, the idea that there are specific treatments for specific illnesses, because without that, the DSM starts to sort of starts to fall down.
Yeah, yeah, absolutely. And the people who were trying to defend psychiatric diagnosis in the 1970s against attacks by people like Thomas Sowers, and also the Rosenhan experiment that appeared to undermine the validity of psychiatric diagnosis, quoted the specificity of drugs in particular as, you know, one thing that supported the diagnostic project and the whole psychiatric project. Yeah.
And the feeling that I get as I read through sort of chapter by chapter, that there've been two main influences on the development of the disease-centred models, and that's the sort of the need within the psychiatric profession to sort of have an equivalence with physical medicine, of sort of wanting to have more precise and exact treatments, and then the influence of the pharmaceutical companies as well.
I think it started off as a professional thing, and the pharmaceutical, because back in the 1960s and the 50s, the pharmaceutical companies were doing quite well with the drug-centred model. They were persuading a lot of people to take barbiturates and Valium, you know, that would make them a little bit calm. They weren't... I mean, it's targeted at anxiety to some extent, but they were acknowledging that these were mind-altering substances in some way. If you look at the adverts, stimulants as well, you know, these adverts of people looking very sort of pepped up in their nice smart suits for amphetamines. So the drug industry had done quite well with the drug-centred model until about the 1980s. And then, of course, the scandal over benzodiazepines made it unacceptable to be prescribing drugs to alter someone's mind state.
Yeah.
And that's when the pharmaceutical industry produces this chemical imbalance idea and really puts a lot of effort into marketing it and promoting it. So the SSRIs and then the atypicals are marketed in this way as very disease-specific substances. So the pharmaceutical industry has very much promoted and strengthened this model over the last 20 years. But it didn't start it off. Mm-hmm. Although you know, the industry, like any industry, will use whatever's useful to market things. So sometimes they were marketing things as specific treatments in the 60s, sometimes as non-specific. You know, and the other thing that I don't particularly write about in this book, but have done elsewhere. The other thing that I think is really important is the political context. The disease-centered model of drug action supports a disease-centered model of a disease model of mental disorder, mental disturbance. And that leads to a nice, simple, technical solution, technical management plan for dealing with a whole variety of what would otherwise be very complicated problems for any sort of political system to deal with. Yeah. In particular, you know, containing behaviour that is regarded as antisocial or disturbing, but somehow doesn't easily fit into the criminal justice system. And I think it's that sort of political backing that has really led to the success of this model.
So the development of the idea of community care very much chimed with what was already starting to happen in the psychiatric profession, sort of in the late 70s, 80s.
Yes, I mean, community care is interesting, isn't it? Because it was very progressive. But it was also, you can see this in President Kennedy's speech in America, it also depended on a sort of simplistic view of biological psychiatry, that, you know, there are these diseases out there, now we've got these new drugs, and we can treat people, so it's fine, we can shut the hospitals down, don't worry, they're all cured. But there were many very progressive people. I mean, the whole Italian reform movement to shut down the hospitals came from people who were very critical of medical model psychiatry and trying to do something different.
For sure. What's remarkable to me is how some of these ideas and theories, if you like, have been built on perhaps even single studies. And in spite of a remarkable amount of conflicting evidence, sort of diverse results from different studies, you know, an idea can still survive, sort of, you know, if it has enough marketing. And yeah, there's
duration of untreated psychosis being an example. I mean, that, you know, that's been an idea that's been around for years. There's never been any evidence to support it. It was always known that people who had a sort of long, gradual breakdown did worse than people who had an acute breakdown, especially if there was some sort of obvious stressor. And that was just forgotten, and then suddenly this new idea of duration of untreated psychosis appeared, and it seemed to take about 5, 6, 7 years before a few voices were heard within mainstream psychiatry saying, hang on, this doesn't all add up, really there isn't any evidence. And even now, you know, it's still talked about, isn't it? And some people, I'm sure, still feel it is established.
Yes. And you make the point in your book that certain individuals like Peter Breggin, like David Healy, were sort of targeted by pharmaceutical companies in particular ways, but their main tactic is just to ignore contradictory evidence, to sort of build up enough momentum behind a drug, and then it's already established, it's in place, and they can just ignore the rest and carry on as before.
Yeah. I mean, the debate about antidepressants, I've been saying for years and years, you know, the antidepressant research doesn't add up, but it doesn't seem to make much difference.
Yeah, indeed. Before we go to the break, I'd be interested to hear a little bit more about, I suppose, your personal journey in your career as a psychiatrist, and I suppose a little bit about your take on the psychiatric profession. I should let you know, probably in the billing for this event, it said something like Joanna would be in conversation with a local psychiatrist. And I think we contacted between 70 to 80 psychiatrists to invite them to be on stage with Joanna. And we're very friendly. Last time we had, who did we have last time? Was it Richard Pemberton last time? And you know, he came and was a very important part of the evening, and we were friendly, and he was friendly, and it was a good conversation was had. But we had no positive response from 70 to 80 psychiatrists. Either we had no response or hostile responses. So, you know, I'm very interested in this phenomena and what you take on that. But maybe, and sort of, I suppose, how you've come to take a different path. I imagine there's a lot of sort of intelligent people in the profession, well-meaning people in the profession, and yet, you know, you're quite in the minority. I mean, there's the Critical Psychiatry Network, which is maybe you could say a bit more about that as well. But yeah, if you could say something about how you got into the profession, what inspired you, and what your take on the profession is now and your place in it.
Well, I think that I ended up in psychiatry because I did medicine, and it wasn't really me, just sort of, you know, diagnosing pneumonia and things like that. I was always more interested in people, politics, philosophy, ideas, things like that. And quite a lot of people end up in psychiatry for that reason, because those are their interests, and that's the part of medicine that, you know, that enables you to explore those sorts of ideas. And many of those people are quite critical and progressive, or, you know, they may not sort of be very overtly critical, but they're generally fairly progressive. But I also think that there are obviously other people who go into psychiatry really wanting to be neurologists or proper doctors, and feel very threatened by anything that suggests that mental health might be different from the rest of medicine. I think we've been seeing that quite a lot recently. The new president of the Royal College of Psychiatrists, who's not at all a defensive person, but has been making a lot of statements like this, you know, that it's, you know, the same as mental health is the same as physical illness, and, you know, how can you suggest it's different, and if you suggest it's different, somehow you're discriminating against mental health. So I think there is that defensiveness within the profession. Yeah. When I haven't done it for a while actually, but I used to go around and do a lot of talks to groups of doctors. No, I did quite recently. There's almost always a minority in the audience who agree with me to some extent. And so I think there are a sort of minority of psychiatrists. And I have done debates. I've done debates with Trevor Turner and Mark Salter from Hackney, who, you know, have fairly reasonable views about medication. In fact, Trevor Turner was on a television program with Rufus May, and he described the effects that antipsychotics had in a similar way that I might describe them. You know, this is a drug that we give that might suppress the symptoms for a while. Yeah. So yes, there are, you know, psychiatry is a mixture of views. I do worry that it is becoming more medical, and that those critical voices that I think were probably more prevalent in the sort of 60s, 70s are dying out. But not completely, because we have quite a good number on the Critical Psychiatry Network.
And what do you get up to in that network? Is it you meet, I presume?
We meet a couple of times a year. We have a conference once a year. We've done things. We actually got together to put in some evidence to the Richardson review of the Mental Health Act back in 1998, when the Mental Health Act was when the first process of that review that went on for about 10 years. So we put in evidence to that on several occasions, and to the NICE guideline committees occasionally and things like that. So we're sort of a combination of trying to have a public voice that's alternative, that's different, that's representing a different sort of psychiatry, or representing a different view from the mainstream, and a support network. Yes. Because lots of us get criticised a lot of the time, so that's important.
And I mean, how possible is it for you to follow through with the ideas you believe in within the services, you know, the service that you work in?
Oh, that's a good question. It's quite difficult, and I often get asked, you know, whether I prescribe antidepressants, for example. I mean, most of my patients are already on a lot of medication, so I spend a lot of time trying to get people's medication load down, with their consent. People have relapses, and I would use medication in those circumstances. It's impossible not to, really. There's an expectation that you would, and anyway, people now end up with a home treatment team and will be put on the medication by them, if not by me. And with things like antidepressants, what I tend to do is, and mood stabilisers as well, where my view is quite divergent from the mainstream, is explain to people that there is this view of antidepressants, that they are effective, that, you know, they will help reduce your depression. And if people want to try them, I would go along with that and just try and help them use them safely, not be on them too long, come off them gradually when they're ready. So I feel that I have to, you know, I work in the mainstream in the NHS. I feel that I have to put the mainstream point of view to my patients and enable them to have that treatment if they want.
But would you let them know about all the possible effects of the medication? Because it seems to me that, you know, more informed, more information is kind of needed. And would you? I mean, because you make I think a very very important point about the need to see the effects of medication as a whole, rather than these are the sort of disease, these are treating the disease, these are the side effects. I mean, side effects is just spin, essentially. These are the effects of the drug. You know, do you feel that you have the opportunity to talk to people about these are the effects that they're likely to have in that way?
I do, but I am constantly amazed by how many people want to take psychiatric drugs. I suppose it shouldn't surprise us, really. You know, there's always been a large market for mind-altering substances of one sort or another. And you know, and people have lots of reasons for wanting to think that, you know, this pill will sort things out for them. So I do discuss side effects, and I'm constantly amazed at how many people don't seem to care about them. I mean, many people have been in the system, I suppose, for so many years and taking so many different things.
Right. Yeah. Okay, well, probably that's a good point.